Hi there, I'm Dr. Clark Damon, and I want to present to you a simple Neoconvert case that we did in our office. Neoconvert is a simplified conversion workflow for fixed full arch cases. So let's begin. Here's our preoperative pantograph, and we have a 59-year-old Caucasian female, ASA 2. She is being treated for hypertension and depression. Prior surgical history, she's had a hysterectomy. She has no known drug allergies, and her medication that she's taking is Lexapro and Losartan. From the panoramic image and from our clinical assessment, we can find that our patient here is suffering from generalized caries on all remaining teeth, multiple abscesses. In fact, a few of them are quite large. Several broken and fractured teeth. She also has a poor and uneven occlusal scheme, a relatively deep bite, and chipped teeth. She, was generally approached about saving teeth. There are some teeth that could be saved by traditional dentistry. However, she's had a long-standing history where traditional dentistry has failed her, and so she is seeking a implant solution, a solution to get rid of her teeth, get rid of her dental related problems. Here is a preoperative smile photo. This is the maximum amount that she can smile. We asked her for a very large reveal that she could give us, and so we have not a very high smile line in this case. So the risk assessment here for a high smile line is very low. Once we got into surgery, the case was done under general anesthesia. There was a nasal intubation. And once we got started into surgery, we removed all the teeth. We performed a very large flap. We elevate up to the base of the zygomatic buttress. We elevate the floor of the nose, piriform rim. We also pull the palate together, and so we get a very broad visualization of all of the anatomy and vital structures of the maxillary alveolus. So once the teeth are all removed atraumatically, we then begin to perform our alveolectomy. We want to prepare the maxillary shelf, and we want that really flat to the occlusal plane. And as you can see that we've done that. The next very important thing that we do is we want to confirm that we have achieved an appropriate alveolectomy and that we have an appropriate or adequate amount of restorative space. And so we can do this with a clear duplicate, or in this case, we just utilized the patient's conversion prosthesis. And I went ahead and used a 702 burr, and I made 3 markings that were all going to give me at least 15 millimeters of restorative space. And so what we are going to look at here is looking at the bone windows. So I want to look through this prosthesis, and I want to make sure that the maxillary alveolar shelf is prepared up to the level that I desire so that we can have proper restorative space, and this is just confirmation of adequate alveolectomy. And again, here what we are wanting to measure is 15 millimeters from the incisal edge. And as you can tell, we've achieved our desired result. Once we have the adequate alveolectomy, now we are able to do what we all get excited about, which is to prepare our osteotomies so that we can place our implants. On a relatively standard case, one where I do not anticipate any zygomatic implants, I will prepare the anterior first. My approach is always to go to the nasal crest when possible, because this gets our implants shifted to the midline, away from possibly interfering with our posterior implants. So nasal crest approach is done first, and here you can see that we are beginning our osteotomies. After we are feeling the bone and we've determined our final osteotomy width and length, then we can place our implants. And here, as you can see, we've placed the maxillary right, the number 7 implant area, and we are getting that to depth. What's pictured there is not the final depth. However, in the middle 2 pictures, this is where I am selecting the appropriate angled implant, whether it's a 30 or a 17, and then I am changing the timing so that I can get the multi-unit screw channel to be as close to the cingulum of that lateral incisor as possible. And you can see in the middle 2 images, we have achieved that. And on the far right side, I am screwing down and placing our multi-unit abutments. I do believe in this case the number 7 or the patient's right side multi-unit abutment is a 1.5. That means that implant is 1 millimeter subcrestal, and I believe on the patient's left, the number 10 implant is a 2.5, meaning that implant wound up being roughly 2 millimeters subcrestal. After the anterior implants are done, on a relatively easier case, we can then go to what I call the middle, and that's what we did in this case. There is no chance of a zygomatic, so I went ahead and just did the middle implant. Here, this is our posterior tilted, so we are anterior to the sinus. Clinicians can take note that we are slightly palatal on our initial approach for the osteotomy development, and that is because the palatal wall will push us buccal as we widen our osteotomy and as we place our implants. In the middle too, you can see that we are placing roughly 4 3/16s in the posterior region, and we will get those to a subcrestal depth of 1 millimeter. Here we are verifying the proper timing of our middle implant here, the posterior tilted, anterior to the sinus. On the left side of the screen, you can see that we are vying for a 1 millimeter subcrestal position of that implant. And then I have now placed a 1.5 30-degree multi-unit abutment. And I close the patient down. And as you can tell, we have the multi-unit screw channel access to go straight across into the cingulum of the opposing arch, and you can see that bilaterally. This is going to give us a very slim and proper fitting prosthesis. It will not be bulky to the patient's tongue. They will not have speech trouble. And so we use the opposing arch to help guide our screw channel access, and that dictates the proper timing of the implant, as you can see, as we rotate that around with our driver. And again, we are preferring a 1 millimeter subcrestal position with a 1.5 millimeter abutment. And last, bilaterally, we're placing our most posterior implant here. We are going posterior to the sinus. And as you can tell, we are preparing that with the spade drill. We will take that up to a 2.9 or the Neodent 3.5 drill, and we will stop there, and then we will advance our implant. Here it looks like we are placing a 4.0 by 18, possibly a 4.0 by 20. But in the posterior region here, a 18 is the most common length for myself. And again, we utilize the same approach. Back in the posterior pterygoid region, we need to make sure that we still have a slim prosthesis. And so we are checking screw channel access bilaterally. We also need to be looking at path of draw and insertion. And so that will dictate if we can use a 17 or a 30 degree multi-unit abutment. We do not want these too far off from our anterior implants. And so we're kind of looking across the arch, we're looking anterior and posteriorly, we're looking medially and laterally, right and left. We're trying to make sure that the path of draw is within the confines of what the system can accommodate, and also maintain a slim and thin prosthesis. So again, even in the most posterior aspect in the pterygoid region, we are having the screw channel access come out in the opposing central fossa. Here we have our completed arch. As you can tell, the palate is brought together. We have a very flat, very nice maxillary all-on-4 shelf prepared. And all of our implants are sufficiently palatal, not excessively palatal. However, they are not buccal either. We are trying to leave 2 millimeters of buccal bone to help resist any post-operative resorption, and we want to keep that buccal plate as alive as possible. Utilizing the posterior implants here, we are able to also minimize our cantilevers, and in fact, we have a no cantilever situation. What is not pictured here is the rotary tissue punch, and we like to use those. That way it helps make sure that we get our sutures away from our multi-units, and we get a very nice transmucosal punch through. As you can see here, it's already been done, and as we are looking at this, we can actually see just the tip tops of our multi-unit abutments. That lets us know that we have appropriately thinned and trimmed our palatal tissue, and we have actually brought that buccal. So now not only do we have adequate buccal bone, we actually have a very nice palatal connective tissue or palatal keratinized tissue buccal to all of our multi-unit abutments. This will resist any insults that the patients can throw at them longer term. We can use a combination. My recommendation is to use 2.0 chromic gut. It is much stronger than your typical 3.0 or 4.0. Chromic gut resorbs, and this, nothing is more frustrating to a surgeon than when your suture breaks. And so utilizing 2.0 is a very strong suture. Now we have placed the Neoconvert copings on, and they are all held in place by the capture pins. As you can see there, those are the white items, with all of our really good buccal keratinized gingiva. We are very happy with this result, and the tissue here is very nice and tight. Okay, and it's all sutured down well. The other pearl here that we can see in our case is that we can see all of the Neodent or the Neoconvert copings. If we cannot see the Neoconvert copings, it is highly likely that they will not pick up when we go to add our acrylic to capture this. So we want to make sure that our verification copings are proud of the tissue level. If you want to find out more about that, please watch my webinar on pearls of the Neoconvert system and how we need to thin and trim our tissue, and the tissue needs to be very tight. We do not need our tissue swallowing our neodent copings. After we are very happy with the look of our Neoconvert copings, and after we have verified that our conversion prosthesis fits and doesn't move around, isn't loose, and that we have a proper occlusal plane, proper midline position, and also proper occlusion, then we can hook up our prosthesis. The way that we hook up our prosthesis is with acrylic. There are multiple acrylics on the market that you can use. I would recommend using a auto mix, such as a Voco. Patterson brand makes a hard reline material. You can utilize either of those. That then sets up and captures our Neoconvert copings, as we see here. So in this case, we had a successful capture of all of our Neoconvert copings. And then we go in and do all of the laboratory steps for the Neoconvert system to convert this into a wonderful Neoconvert temporary acrylic prosthesis. As you can see here, we have adequate restorative space. As you can see here, we have not excessively drilled through our prosthesis. It is going to be very, very strong. It most likely will not break in the postoperative period. And all of our contours are flat or convex. There are no concavities here, so it's highly cleansable, highly polished, and we have a great result. This is what these cases look like on x-ray. So we want to take a follow-up x-ray, one to confirm if any implants have failed, which are unlikely. The other is we want to confirm full seating of our Neoconvert copings. And here we can tell that everything is fully seated upon delivery. And here's our patient's beautiful final monolithic final zirconia prosthesis. Of course, there's different ways that you can make these. You can utilize tie bases, you can utilize direct to multi-units, you can utilize a titanium bar with a milled zirconia overstructure. Too many different ways to skin a cat. Many work in every clinician's hands. However, when looking at whatever system you're using, we need to make sure that we do not have any areas of concavity. We want to make sure that the intaglio is highly polished. This is highly polished zirconia. We will not have plaque or debris adhering to this. Thank you for allowing me to present this case to you. I hope it sparks some interest in the Neoconvert system and what it can do for you. I have a webinar. Please visit me on my YouTube page, texasimplantinstitute.com. You can also find out more tips and tricks on how to make your arches simpler, more predictable, and also there's a webinar on how to utilize the Neoconvert system with my spin and my take on it. So direct you to check out the Texas Implant Institute YouTube page